So the next part is a
Yes, sir.
panel discussion, and that's on chronic GvHD, how to best manage in India, in Indian setting, what we should do in our practice. So this is more practical oriented panel discussion of real life scenarios. So I will invite Dr. Chintan Vyas, who is moderator for this session. Dr. Chintan is a senior consultant in bone marrow transplant and pediatric hematology oncology at Narayana Hridayalaya Mumbai Center SRCC. And Chintan, over to you. Please introduce the panelist and let's start the panel discussion. Thank you.
Yeah, thank you, especially to give me the opportunity to moderate this panel. Uh, Let me just try to share the screen.
Meanwhile, as Chintan is loading his slides, I would make an announcement that next month we don't have a webinar. We have our annual conference of Society of Pediatric Cell Therapy and Transplant in Bangalore on 28th February and 1st of March. I would encourage all those who have not registered for this annual meeting to register at the earliest so that they can enjoy all about transplant and cell therapy in beautiful city of Bangalore on 28th February and 1st March. And following that, in April, in March, we will have the next webinar, March end. Thank you. Over to Chintan.
Yeah, so let me just load the slide. I'm not able to share it from here. 1 second. So in the meantime, I will start introducing my panelists. My esteemed panelists are Dr. Deena Dayalan, Dr. Ruchira Mishra, our chairperson, Dr. Neha Rastogi, and Dr. Prashant Hivakar. So let me know if you can see the screen.
Yes, we can see. Please make it full screen.
Yeah. So in the meantime, I'll just ask Dr. Prashant when or what time he is leaving, so I can pose a question or case to him first.
Yes, please, Chintan.
Yeah. Is my slide moving? Is my slide moving?
Yeah.
Yes.
Yeah. Yeah. So let's start with the last case which I wanted to discuss because Dr. Prashant would have to leave. And this is one of the very complex case. And now this case I want to discuss because we are dealing with a lot of immunotherapy, cellular therapy, and CAR-Ts. And then we are transplanting the patient. So this is a real life scenario which I dealt with. He was an 11-year-old boy diagnosed with pre-B ALL, but multiply relapsed in CR4 when he came to me. He also had underwent one matched sibling donor transplant in 2019 and then relapsed and then again relapsed, combined relapsed and received CAR-T therapy in Singapore. And then they came to us. So it's a very high risk transplant, CR4 transplant. And we can't offer this child to have another relapse because this is the one and last time, but because they have received CAR-T therapy, so the transplant was offered. It's a multiple relapse patient. So we prefer to do haploid identical transplant over matched sibling because immunologically probably I thought that matched sibling did not do their job. And that's why I choose the haploid identical transplant with T-cell deplete setting. I used intensive conditioning. The patient thankfully did not receive TBI in the past. So we received TBI-based conditioning and cyclosporin alone as GvHD prophylaxis. Now, this was a case which just gave me really a tough time in the first 100 days. This patient had a BK virus grade 4 hemorrhagic cystitis. BK in the blood was about 1 billion. USG showing massive clots requiring manual clot removal and continuous bladder irrigation. Also had a CMV pneumonitis and adenoviremia. Remember this ATG dose which we used in this protocol, which was again a tailored based ATG dose discussed based on the parachute trial and based on the absolute lymphocyte count at the baseline. but still the child developed multiple infections. And look at this timeline from 0 to day 250. You name the infections, all the infections this patient had developed. Pancreatitis, the E. coli infection, gut sepsis, viral reactivations, pancreatitis, UTIs, and recurrent infections. And this was up to day 250. Now, when we are dealing with these type of infections, you are almost, you are every day you are fighting a new viral infection or new bacterial infection in these multiply retreated patients. Now, your job was to prevent the GvHD, and that's what we use the T cell deplete setting with ATG in this setting. But still, the patient developed mild GvHD in the upper gut, and I held on omnacotil for a long because this patient was having viral reactivation, and administered Jakavi also in this patient. But then this patient had a flare of gut GvHD and hyperbilirubinemia, mildly low albumin, ascites. And at that point of time, because there was an ongoing gut GvHD and there was a mild skin GvHD also, I had to give some steroids, which child was already receiving Jakavi. I was holding on steroid because the patient was having multiple infections in the past. This point of time, as Dr. Prashant has rightly mentioned, that we have to question our diagnosis, whether we are dealing with infection, drug toxicity, or GvHD. We did the liver biopsy, and this patient had a EBV positive in the liver, which was very odd, and also in the blood, which was 22,000 copies. Now, remember, this patient is a post-CAR T, post-transplant patient. At this point of time, patient had 0 B cell, even after 6 months of transplant, but he developed EBV-related disease, and which is not unheard of. So this patient had a gut GvHD, liver GvHD suspected to have. We did this endoscopy also, not very classical finding of histopathology in the gut, but clinical background was very suggestive of gut GvHD. EBV was a confounding factor, bystander in this patient, and eventually the patient developed thrombotic microangiopathy kind of feature like capillary leak, nephrotic range proteinuria, and worsening on TMNA. Now, what treatment I offered during this period of time? I gave Jakavi, steroids with whatever dose suitable in terms of to counter the infections, and these two were my main agents. So my question to Dr. Prashant, that that we try best to prevent the GvHD, but in multiply treated patients, you don't know how your immune dysregulation happens. And we are dealing here in this patient with chronic GvHD kind of picture with TMA, with EBV infection. So the first treatment, again, what is the best preventive strategy? And this is an ALL and CR of 4. So you have to be very careful in what immunosuppression you are using. The second question is role of steroid sparing agents. In the very beginning, upfront, challenges in post-CAR T, post-transplant. And the last question is, how do you tame the viral reactivations, infections in your chronic GvHD treatment? So you can take questions one by one, and you can suggest what could have been done better in this case, or how could we have done differently in this case. Over to you, sir.
Yeah, so rather than these questions, if you go back to your timeline, Chintan.
Yeah.
So this was alpha beta deplete transplant, is it?
Yep.
And did you give me any memory T cells?
So we gave first we gave at on day 21, and then we gave on day 45. After that, he started developing low-grade gut GvHD, because of which we had to interrupt the T cells.
Go to the timeline. Sorry, wait, go to the timeline.
Yeah.
Yeah. So here, you gave what immunosuppression was given to this child?
Cyclosporin. And it was stopped by day 30 because of significant viral reactivation. This patient had a CMV on day 1, had a CMV of a lakh, or adenovirus also in 50,000. So very bad viral reactivation, probably because of the previous multiple treatment, CAR Ts and all those things. Yeah. And so we stopped the cyclosporin by day 30.
Yeah. So how many memory T cells did you give?
Two by day 21 and day 45, day 30, day 60 around. So we usually start 50 post engraftment. We start 50,000 per kg, and then we escalate 50,000 every time. Post engraftment. Memory cells per kg.
So you don't give 5 million.
So
kg?
no, so we had tried multiple doses. Initially, we had tried. So in the
No,
pre-engraftment,
I don't want to, Chintan, hang on. Let's not go into what you have tried before.
yeah,
I just want to know about this particular patient. So you gave 150,000 per kg,
yeah.
not 5 million per kg.
No,
That's
no, no.
correct.
This is the post-engraftment.
Yeah, post-engraftment.
Yeah.
And day plus one, did you give any memory T cells?
Day plus one, yes. Day plus one in this case, we gave around 0.5 million per kg. 1 million per kg, sorry. Yeah.
Okay. So, and then you gave 50,000 and 50,000.
Yeah, 50,000, 1 lakh, 1.5 lakh, like that.
So how many T cell doses have you given?
2.
Okay. So less than 1 million per kg of memory T cell copper, okay, in my experience, has never caused any GvHD.
Yeah.
Okay. Only when you go surpass the dose of 5 million per kg memory T cells, maybe there is a risk of GvHD. With 5 million per kg also, we have not seen any GvHD. Okay. Now, having said that, so when I have given such few numbers of memory T cells, and if I'm pretty certain that these are memory T cells, okay, then I wouldn't be thinking about GvHD diagnosis in this patient at all. Okay. So when you made a diagnosis of upper GI GvHD, okay, that was made on the basis of clinical symptoms, or that was made on the basis of biopsy?
Both.
Okay, so what did the biopsy show?
Biopsy was showing apoptotic bodies and grade 2 GvHD in the duodenum region. Duodenum.
I think it's very, very unusual. Firstly, you have to understand upper gut GvHD is a phenomenon that is very, very rare. Okay. You can possibly see upper gut GvHD. I can imagine seeing it after PTCY when you're giving huge number of T cells. But in any of the T cell deplete transplant and the T cell deplete transplant like this, you have to think twice before making a diagnosis of upper gut GvHD. Okay. So that would be my first thought. Okay. Because if this was an upper gut GvHD and you are intensifying immunosuppression, then you are already on the wrong. Then one is already on the wrong track. So that is a very important point for everybody to understand, that upper gut GvHD. I mean, it is very rare. You have to be very, 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 very thorough to make a diagnosis of upper gut GvHD if one is making a diagnosis of upper gut GvHD without any other GvHD symptoms. So that's my first starting point. If you have given appropriate number of memory T cells, then the risk of viral reactivations is much lower. So that's something that I think, Chintan, over a period of time, you have to sort of refine in your own center. What is the correct number of memory T cells for your own center, so that you don't see viral reactivations, or you get a good control of viral reactivations? And when and how many topos do you give? So I think if you do these two things, you will probably not see these many complications.
So my question is, when we use intermyeloablative conditioning, right? Whatever the serotherapy we use, right? Even in a T cell deplete setting, that's not absolute. So we have done quite a good number of T cell depletion. Our T cell depletion chronic GvHD rate is less than 10%. Now, this is a case which we would like to discuss because we are discussing in a meeting, and the spectrum of GvHD in the background of infection. That is a question which I would like to tell you, particularly in the patient who has received multiple lines of treatment in the past. Now, in these type of settings where you have a lingering GvHD, let us say the gut, skin, liver, all these things, multiply involved organs, how would you manage your immunosuppression? This is a question pertaining to you in terms of that. How would you deal with viral infections and GvHD simultaneously?
You can only win over one thing, Chintan. You can't win over two. Okay, so that's a short answer. So I think you can win over such patients if you preempt all of this. Yeah.
Right.
So if you think through it before, that this patient will be at risk of multiple viral infection, and that's the reason why I would want early immune reconstitution in this patient. Okay, but without risk of GvHD. Okay, then you will win over this. So you have to find a middle way. Now, what you're showing to what this case is that you're showing to me is that you've given so few memory T cells, and
So
still
the
you're
question
saying,
is here that that a lot of centers who are using memory cells, as you have rightly mentioned, that the dose is not.
Chintan and Prashant, I would
Yeah.
like to intervene here. We should
Yeah.
stick to the topic chronic GvHD.
Yeah.
That was the main topic. This is
And
more
we can
like going intensely into
hypothetical
So let's
discussion.
wind up this case and move to
Yeah.
the next case. Thank you.
Sure. So my next case, as I'll go back to my case 1. Yeah. So this is to Dr. Ruchira. She is a case of AML, high-risk AML, underwent haploidentical transplant with ATG, fludarabine, busulfan-based conditioning, and PTCY, cyclosporin, and MMF. Now, as we have learned that acute GvHD sets in and then chronic GvHD, because the most common risk factors for acute chronic GvHD is acute GvHD. And this patient developed grade 3 skin and GI GvHD, biopsy proven clinically, also given steroids. But he was a steroid dependent. So he was responder to steroid, but he was kind of steroid dependent person. And then also developed CMV and BK virus infection because he was a PTCY graft, and then subsequently developed a chronic GvHD. Now, the question to you is that what kind of chronic GvHD she has developed is mainly lung GvHD triggered by infection and again treated on the ground of steroids, FAM therapy, and Jakavi, and also added imatinib for a brief period of time. So the question to you is, we should be very precise. We can be precise in answering these questions. That how would you deal with steroid dependent? I would like to answer the steroid dependent part of GvHD, which goes from acute to chronic. And what is the best second line agent you would use in this setting?
Thanks, Chintan. So basically, steroid-dependent GvHD is generally an inability to taper off your prednisolone, or you have to continue at doses around 2 milligram per kg per day after you've seen an initial response, or if you have a recurring, every time you try and taper the dose, you have a recurrence of your GvHD or an acute flare-up. That's what we generally call a steroid-dependent thing. Just as Prashant had said, we would first need to actually confirm that we are actually dealing with GvHD and not with any other mimickers. So try and rule out infections in these patients. Make sure that you're not dealing with CMV, especially because CMV tends to mimic GvHD as well, especially where the gut is involved in those patients. And then think about seeing if you can get a biopsy. Lung may be very difficult to do that, but skin or liver or gut may be an easier option to look at getting a biopsy in these patients. And then think about adding a second agent to these. Most cases, ruxolitinib has shown very good results, especially since we do not have ECP readily available. Ruxolitinib would generally be a go-to drug as a second choice or a second line agent in this. And then after about a week, 2 weeks, we try to start tapering the steroids if we start seeing a response in these patients. I would generally add on an antiviral as well, because most of these patients will get lymphopenic and then will have an increased predisposition to develop viral infections or reactivations. So kind of preemptively add an antiviral prophylaxis to these patients would be a general consensus.
So where would you place imatinib kind of drug in a lung GvHD setting? Before Jakavi or after Jakavi?
After Jakavi, generally, imatinib is generally an antifibrotic agent of the way it works. So it's very helpful if you have an obstructive type of lung GvHD, and has shown very good results with lung GvHD or skin GvHD contacts as well. But it comes in as a third agent. It doesn't supersede ruxolitinib in any case. Both agents have to be given over a long period of time. So don't expect miraculous recovery in any of those cases. It has to be given for at least 4 to 8 weeks before you start seeing a response, and then maybe need to continue it for longer periods, maybe 6 months, a year or so, to see some kind of improvement in these patients.
Right. So this is what Dr. Archana is highlighting about how to define the steroid-dependent GvHD and how to use the second-line agent. Now, moving on to a second case, Dr. Neha, is again a leukemia case. This is a 10/10 match-related donor from female to male. Conditioning was ATG cyclo-TBI with GvHD prophylaxis standard as cyclosporine methotrexate, and developed a steroid refractory extensive chronic GvHD. Required steroid and Jakavi in the first go, but also had a CMV disease. Now, we sometimes deal with these type of complications where we have to treat both together. We cannot 100% identify one versus another, and we have to, it is always wise to treat both together so that we are not left with incomplete treatment. Now, this patient from day 150 started developing flares of GvHD on tapering of immunosuppression. Although the tapering was very slow, as you can see from day 150 to 350, he had multiple flares, and eventually post 1 year, he started developing skin and liver GvHD. This patient has received steroids, very slow tapering as suggested in chronic GvHD with Jakavi, also a good dose of Jakavi, but still developed skin and liver GvHD because the predominant factor, it was a female to male donor transplant, although it was a match related. And eventually developed a bit of bad liver GvHD in terms of the bilirubin maxed out to 3.5 with platelet count dropped to 50,000 and hyperbilinemia also. Now, the catch of this patient that because of the previous history of a lot of steroids in the ALL treatment, this patient developed a significant bony problems, and this was an adolescent boy. He developed avascular necrosis to that extent that required a femoral osteotomy. Now, when you are dealing with this patient who was already on Jakavi, a good dose of Jakavi and intermediate dose of steroid, now you don't want to use steroid because of the bony complication. What would your preference in these type of settings? I would call it as a Jakavi fatigue. We have proven this case by liver biopsy, and it was a classical picture of a GvHD in this case. This patient is now having liver, skin, oral, and musculoskeletal. So all the four systems of a classical chronic GvHD is fitting into this picture. Patient who has received almost a year of Jakavi and steroids, and also counseled about the newer agents which is there into the picture. So how would you deal with these kind of cases, Dr. Neha?
Yeah. So, I mean, this is one of those cases you always dread in your for not having in your practice. It has all the complications in GvHD profile what you can have. So at last, if you think that the Jakavi is not working and you want to change to the next thing, you can have other drugs like methotrexate, which we are using in a low dose because that acts on T cells, and you can have your steroid removal in the earlier phase itself. Okay. Now coming on to the question which you have given, what will you use, ibrutinib or ROCK inhibitors? Personally, I haven't used both of them in my practice, but if you ask me theory-wise, ROCK inhibitors would be a better choice in this because the ROCK inhibitors, as they say, the mechanism of action is at three parts. First, it helps in the T cell differentiation. It also reduces the fibrosis, and it also suppresses the inflammatory cytokines. So, as we say, when we talk about the pathophysiology of chronic GvHD, it includes both things. It includes first, there is an inflammatory phase because of the T cells, if you are talking of the acute and chronic one, and like in your case, and it also, and next is the fibrosis phase when you have B cell activation, and then you have fibrosis. So for all of the three mechanisms, I think ROCK inhibitor would be a better option. But there are studies with the ibrutinib which shows that the response rate of ibrutinib is also very good because it doesn't eliminate B cells, but it blocks their pathway. So I think it is wise to try
at what point of treatment you would introduce these drugs? Maybe after 3 months of treatment.
As I can see your timeline, you have used the steroids for quite long. So I would have introduced the other drugs little early on. Right. I would have also tried, as I've said, methotrexate. I would have tried for other things like etanercept also to withdraw the steroids from my profile.
And just last question, which drug you use best for the liver GvHD in conjunction with others?
So liver GvHD is always the difficult one. people say that ibrutinib works better, but
So most of the studies shows that ibrutinib, this ROCK inhibitors, they all work for a fibrotic process mediated GvHD
yes,
like skin, musculoskeletal, muscle,
yes,
joint, and all. Unfortunately, the liver, all the studies which have either it is Jakavi or it is other drugs, Jakavi works the best for the liver, but rest of the other drugs, anti-fibrotic drugs, has not shown much. We'll show in some of the slides. I'll throw you quickly to this literature. But yeah, as you have rightly said, that nothing, no one answer fits to this. But newer drugs initiation earlier in the treatment, that is probably the key. Now, the last case which I want to discuss with Dr. Deena Dayalan, I think this case was provided by him only. This patient underwent liver transplant in the infancy and then developed AML with Flubu-Mel and developed infections, as we all see. And then at the later part, post day 100, he developed lung GvHD, I suppose. And then at that time, ruxolitinib and belmicidine was offered but couldn't afford, and started on imatinib, as like what Dr. Ruchira was saying, that it should be Jakavi first and then imatinib, but there is a cost constraint. There are always reasons to start one versus another. And then eventually the patient was started on Jakavi. This was a CT chest which Dr. Deena has shared, and this is a PFT, so definitely bad chronic lung GvHD. And the NIS score was high, and this patient ultimately developed a lot of infections and complication and couldn't be revived. So the question to you, Dr. Deena, that how should you bronchiolitis obliterans syndrome be diagnosed early in an emergency scenario, emergency visit, and what fibrotic mechanism sets in? Once it sets in, is it salvageable or not? And how would you target your B cell directed treatment? So it's not only about T cell, you have to also think about the B cell directed treatment. So where would you place those treatment in your practice? Over to you, Dr. Deena.
Yeah, thank you. Since the patient had an myelability based condition, also an acute skin GvHD, the child is very prone for a chronic GvHD. So we have to monitor the pulmonary function test once in 3 months. Suppose the pulmonary function test there's a drop in so less than 10% from the baseline, then we have to do the CT test to rule out the boop, and then we have to do the ball to rule out any infection. Once we know there's only the bronchiolitis obliterans, then we have to go for the treatment. And come to the second question, do the fibrotic manifestation is reversible? Yes, reversible. And NH lung score is based upon the symptom wise and the pulmonary function test. Whereas NH grade 3 is very severe, that is irreversible due to fibrosis. Whereas NH grade 1 and grade 2 can be manageable with the Jakavi and then ECP and other imatinib, plus or minus belmosid also. And then what lesson we have learned from the B cell directed therapy, as Prashant mentioned, that the T cells and B cells have dysregulated immunity because of the thymic damage and loss of peripheral tolerance. So, and the B cell, aberrant B cell clone give rise to auto and allo antibody production. And then that the example for the that B cell stimulate the macrophage that will cause the fibrosis. So example for the B cell direct therapies are rituximab and ibrutinib. And then based upon certain biomarkers like in a BAF, we can decide this patient response to the rituximab or ibrutinib. We can make out by looking at certain biomarkers, we can make out child response or not.
So in your practice, let us say one patient comes with a bronchiolitis obliterans, like an asthma kind of condition, versus other patient who comes with a fibrotic lung disease. Where do you place a pulse methylprednisolone in your practice, and where do you place the other like Jakavi and ibrutinib? So for the juniors to learn, that let us say if patient is presenting like an exacerbation of asthma kind of feature, would you pulse the patient, and how frequently you would pulse the patient?
See, this child always comes with an acute exaggeration. That time I'll start him on pulse methylprednisolone. Sometimes we give went up to 10 mg per kg also for 3 days. And this type of patient, they respond very well to the pulse MPS. So the patient that comes with acute exaggeration, you have to give the MPS dose. By giving MPS dose, the severity will come down. By then we can add all the other immunosuppressions also.
Right. Yeah. And how frequently you pulse the patient depend on the exacerbation?
Yeah, it depends on exacerbation only.
Right. Yeah.
Because
Yeah.
they are very prone for infections also. We have to be very careful when using the methylprednisolone. So based
Sure.
upon the clinical condition, I'll take a call.
Yeah. Yeah. So
I have one comment.
in
Can you please? So, have any one of you used the newer anti-inflammatory, anti-fibrotic drugs for the lung GvHD? Because once we have a patient, and I was discussing with my pulmonologist who is very much into the interstitial lung diseases, and he suggested us to use the nintedanib or pinphenidone, which are the TGF beta pathways blocker. So, nintedanib was used. It is used for last many years in their patients, especially when the patients develop after like ILD में when the fibrosis sets in, तो ये anti-inflammatory में काम करता है. Then I searched into the lung GvHD. So there are series in which they have used, but still now we have not used. So I was just asking if any one of you have used.
Yeah, actually, practically not we have, except FEM therapy with immunosuppression, we have not
FEM therapy
used.
we all use. These are the newer drugs which we can look into.
Yeah, definitely.
But there's no data on the pediatric.
No literature in GvHD, of course.
GvHD.
Yes,
Maybe the
few
adult.
reports are there. Yeah.
Yeah. So, Dr. Ruchira, the questions to you for our juniors to learn that when the fellows are presenting a case of chronic GvHD, what are the important factors, or when a newly practicing transplanter, what are the important factors to quickly diagnose the GvHD in your busy practice, even when we are doing video consultation? Secondly, where do you biopsy? Where comes the role of biopsy in the chronic GvHD? And the question you have already asked, the biomarkers to Dr. Prashant also, this ST2 and REC3, which is not available in India, but we can read about that. So the question to you, that what is the role of biopsy, and what are the other tests which you, particularly GvHD or genitourinary GvHD and all those things like difficult GvHD, how do you diagnose those?
For me, always a very good history and examination is very, very important.
Yeah.
Make sure that you examine the patient completely, especially in terms of looking at all the skin areas and everything, because anogenital is generally missed. They will never complain about it unless you actually ask them about it and then examine yourself. For the eye, ask them about loss of tears or dryness of eyes, and that should be a routine question every time they come to you for a follow-up, not unless they start complaining, because moment they start telling you about this, that time the kind of GvHD is already set in. Generally ask for an annual ophthal evaluation and annual endocrinology evaluation for all your patients, because sometimes they can actually pick it up faster. The ophthalmologist picks it up earlier. One of the drawbacks is that there may not be a lot of ophthalmologists who are actually geared to looking at GvHD. And so you need to have a dedicated ophthalmologist also that you can keep referring back to your long-term follow-up clinics kind of thing. That is very, very important. In terms of biopsy, I definitely love to have a biopsy before I actually start making a diagnosis of chronic GvHD, especially if it is the gut or it is any other organ system that is involved, like the liver, because there are enough cases to say that this could just be a CMV reactivation or any other viral reactivations, and maybe some kind of a chronic smoldering infection like Dr. Prashant presented in his case as well. So that's very important. Try and do that. Your surrogate markers for zinc would be your PFT. So ask for a pulmonary function test if you can, maybe annually, or ask for a spirometry if you can't. Ask for a pulmonary function itself. So those are the important things that you can. But a very good history and examination are very key for every follow-up visit. And there is a chronic GvHD scoring list that is available by the EBMT. So kind of make sure that you have a printout there for all your patients who undergone transplant and have gone into that thing. So you tick off all the boxes. It's an extensive list and you can't skip those boxes.
And there's an app also called eGvHD Hub.
Yes.
eGvHD Hub, which you can use for your chronic GvHD patient. And these are some of the rare GvHD, esophageal wasting syndrome, BOOP, myositis, cytopenias, which we can diagnose with various techniques. So biomarkers, I'm not going to the detail because we are not using in a clinical practice. So, question about the first line treatment, Dr. Neha. This is a bit of hypothetical question, but now we are having a lot of reliability on Jakavi. Where do you still place a role of steroids and conventional immunosuppression like MMF cyclosporin in a chronic GvHD patient who had an infections? And what is the quality of life you expect with this kind of patients, Dr. Neha?
Okay. So I still put steroids at the first line of therapy for chronic GvHD because it is a time tested and it is always give you the fastest results. It takes Ruxolitinib for some time to show the results. So in the meanwhile, your first line is steroids, which reduce. The mechanism of action of steroids is multifactorial. So that's the reason also that we should start with the steroids. And given that high rate of steroid refractoriness, I don't think so. There is high rate of steroid refractoriness. I think it is less than what is for Jakavi. It is just like that. We use we are not able to draw the patient from steroids. It is sometimes steroid refractory or steroid.
So if you see this slide, this multiple literature, it does say that even half of your patient will be steroid refractory or steroid dependent or not steroid classically responsive. So it is
like most of the times your patients become steroid dependent.
Absolutely.
And you need a second drug. It doesn't mean that if you start with Jakavi, you won't need a second drug. In that case, also you need a second drug because it will not be very fast. आपका तो रिजल्ट आने में थोड़ा टाइम लग जाएगा तो उतने दिन में तो वैसे ही कुछ ना कुछ ऐड कर देंगे. Since anybody has not done the Jakavi as the first line, so we cannot comment on that part.
Sure. So that is a message. That is a message, very important message for the juniors, that steroid still remains the first line option in spite of having a lot of toxicities, and it is a quick agent to act on. And then on the background of that, we have to add the second line and third line
regarding this definition of steroid refractory dependence, so the definition is different for a
acute and chronic,
and it is different from a chronic GvHD. When you are talking about the acute GvHD, you have to test the responses 3 to 5 days, and with a dose of more than 2 mg per kg per day of methylprednisolone. But when you are talking of the chronic GvHD, you have to wait for 1 or 2 weeks, and the dose is about 1 mg per kg per day. And also, when you say about the steroid dependence, then it should be your inability to taper the steroids for 2 occurrences 8 weeks apart, and the dose should be less than 0.25 mg per kg per day.
Yeah. So the question to Dr. Deena is that amongst the available second line agent, we have maybe 10 minutes more just to wind up. Among the second line agent, can we be specific in as far as the organ involved, and which is the preferred second line agent in your kitty for lung, for musculoskeletal, skin, liver, and GI?
So before starting, we have to decide on 8 factors. The first thing is how many organs are involved, what is the organ severity, what is the patient condition, is the patient having any infection or cytopenia, what is the best available treatment in your center, and then what is the cost of the patient. The finance is very important, and based upon should you decide on which treatment you have to start. Especially for the second line best therapy always will be the Jakavi Ruxolitinib is a second best line therapy. In lung, we have to use first is the steroid and followed by the Ruxolitinib, and the plus or minus ECP also can work out in the case. And then if it doesn't work out, go for Belmocidil. And then Ibrutinib work very well in the skin, and then mouth and the GI involvement. For MSK, it's better to use a Ruxolitinib, and in a fibrotic, we have to go for the Imatinib also. And then for liver, Ruxolitinib followed by the CNI, and then plus or minus MMF also we can use it.
Yeah, so this is a cartoon for the juniors. The ROCK, BTK, JAK, and IL-2, these are the common pathways which you have to target. Now, question to Dr. Ruchira is that just for the juniors to learn that REACH 3 and REACH 5 trials have shown a significant results in terms of chronic GvHD for the Jakavi. But for the practical questions, what dose and duration of Jakavi based on age and weight you target in your clinical practice, and what is the commonest adverse event you see, and where do you see the best response of Jakavi? In which organ? Dr. Ruchira.
Ruchira, before you answer, this is the last discussion because we are running out of time. Thank you.
Yeah.
So the REACH-3 trial was the most important trial because that actually showed that over the best available therapy, or BAT as they called it, it really worked very well in terms of showing a good response, overall response to the GvHD. The dose that we generally use is about 5. It's based on your weight, and the dose is generally 5 milligrams per kg per day that we are using. Usually used as a PD dose, which we generally will use. If it's smaller kids, then a smaller dose may be appropriate, and I think the dose is 4 milligrams per meter squared per day in those patients. The REACH-5 trial is generally looking at doing doses for pediatrics, and that is what is the thing exclusively for pediatrics age group from 2 days to 18 years of age. The most common side effects that we have seen with Jakavi have generally been thrombocytopenia and lymphopenias. That is what we have actually seen. And again, an increased risk of secondary infections is what we are seeing.
Right. So I think we can end here. I have not discussed the role of ECP and mesenchymal stem cells here because of the lack of time. But practically speaking, we very less often are able to use ECP and mesenchymal stem cells because of the lack of availability. And we are not very sure about the efficacy also, particularly about the mesenchymal stem cells in our setting. But the Jakavi, ibrutinib, and other newer drugs, particularly belumosudil, which has come into the picture, has shown a significant improvement as far as the trial is concerned, almost 75% response rate. But the cost of belumosudil therapy is very high. It is 6 lakhs for a month of therapy for a 200 mg once a day daily
and you
dose.
have to give it for at least 3 months before you expect any improvement.
Absolutely. So you give 2 months therapy worth of 12 lakh rupees, and then they provide 2 months of therapy free. So it's almost to do a second transplant when you are thinking of using belumosudil in a chronic GvHD patient, although the response rate is very high, particularly in the fibrotic conditions. But we are bound by the finances here. So all the therapies works well, but if you have to target it well in your clinical practice. So I'll end here my presentation, and we can wind up. Over to Dr. Yadav for the words of wisdom in this chronic GvHD topic. Thank you,
Chintan. So as you ended your talk with that, the cost of ROCK2 inhibitor can be as high as a second transplant. So that's the interesting note. In fact, for a refractory GvHD, people have attempted a second transplant to reset the immune system. And I think CAR T cell therapy is something which is coming up to treat GvHD. And that may be something in the future we may hear a bit more about using CAR T cells for treating GvHD. So thank you, all of you, Chintan, for a wonderful moderation, and Ruchira for pitching in as a panelist as well, other than the chairperson session. And thank you, Neha, for wonderful, crisp answers, and Dr. Deena for all the wisdom, experience you have shared. That's wonderful. And Prashant, as usual, a highly experienced transplanter, but we couldn't have him for long in the panel discussion. So it was very useful. Thank you all. We finish here, but I just want to make an announcement that SPECT annual meeting is happening in Bangalore on 28th February and 1st of March. And I would encourage all of you to register for that meeting and attend this meeting in person to learn more about transplant and cell therapy, all the latest things. So please register. We don't have a webinar in February. We will come back in the last week of March. We'll have the next webinar. Thank you all. Have a good night.